Hello, 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 everybody. Welcome, welcome, welcome. Tonight, our special guest is Dr. Jayme Locke, Director of the Comprehensive Transplant Institute at the University of Alabama at Birmingham Department of Surgery and lead surgeon on a study targeting xenotransplantation. Dr. Locke is an abdominal transplant surgeon specializing in innovative strategies for the transplantation of incompatible organs, disparities in access to and outcomes after solid organ transplantation, and transplantation of HIV-infected end-stage patients. Dr. Locke completed her undergraduate degree in biology and chemistry at Duke University, at East Carolina University prior to matriculating to Johns Hopkins Hospital, where she received training in general surgery and multivisceral abdominal transplantation. Dr. Locke completed her Master of Public Health degree with an emphasis in biostatistics and epidemiology at the Johns Hopkins Bloomberg School of Public Health. Her research interests include complex statistical analysis and modeling of transplant outcomes and behavioral research focused on health disparities. She's authored more than 160 articles in peer-reviewed journals and 20 book chapters, and it is an NIH R01- funded investigator. In addition, Dr. Locke is a deputy editor for the American Journal of Transplantation, is an editorial board member for the Annals of Surgery. She is also a member of the American Society of Transplantation, the American Society of Transplant Surgeons, and the American Society of Nephrology, as well as a fellow of the American College of Surgeons, Society of University Surgeons, the Southern Surgical Association, the Society of Clinical Surgery, and the American Surgical Association. Dr. Locke is the recipient of numerous honors, including UAB's Dean's Excellent Award in Research in 2016, named the 2016 James IV Association of Surgeons Traveling Fellows, Top 40 Under 40 by the Birmingham Business Journal, the AL.com's 2015 Women Who Shape the State B Metro Top Women in Medicine, 2017 American College of Surgeons Traveling Fellow, 2018 Association for the Clinical of Transplant Scientists, Distinguished Investigator Award, Translation into Public Benefit and Policy in 2018, and the AST Clinical Science Faculty Award in 2020. Dr. Locke is currently a professor of surgery and the Arnold G. Dyson, MD, Endowed Chair in Transplant Surgery at the University of Alabama at Birmingham, and serves as a director of the Comprehensive Transplant Institute and the chief of Division of Abdominal Transplant Surgery. Tonight, we are going to talk to Dr. Locke about pig kidneys and xenotransplantation as part of her experiences with the UAB team that performed the first such transplant in September of 2021 and announced it January 20th, 2022 in the American Journal of Transplantation, when they transplanted 2 kidneys from a genetically modified pig into a brain-dead recipient. They were the first to transplant genetically modified pig kidneys into a human being. Please give a warm welcome to Dr. Jayme Locke. Doc, how are you tonight?
I'm great. Thank you for having me.
Did I state everything correctly in the introduction?
I think so. I would just clarify and say we were the first to transplant a clinical grade genetically edited pig kidney into a human. So just to clarify that. But yes, everything was great. Thank you.
Please tell us a little bit about how and where you grew up, your education, and your employment history.
Sure. So I primarily spent most of my growing up in North Carolina. I went to college and medical school there, and then went to Baltimore to Johns Hopkins, where I did all of my surgery training. I was there for about 10 years. I did all of my general surgery research as well as my transplant fellowship. And then took my first job at the University of Alabama at Birmingham and have been here ever since, and now in my 11th year here.
Okay, let's talk about xenotransplantation. I have seen it defined on the UAB's website as, quote, transplanting an animal, organ, or product into a human to cure a disease. Can you please explain how this is possible with a genetically modified pig kidney?
Absolutely. So you have to modify the animal organ enough so that the human body doesn't sort of immediately reject it as recognizing it as foreign. So essentially what the genetic edits do is it tries to humanize, if you will, that pig kidney so that the human immune system will better tolerate it.
Okay, let's talk a little bit about why we need xenotransplantation. It's my understanding that kidney transplantation works between 95 to 98% of the time. According to the materials from UAB, about 800,000 Americans are living under kidney failure, 600,000 Americans on dialysis, 240 Americans die every day on dialysis, 5 to 15% of the dialysis patients die yearly. The 8-year survival rate is only about 35%. There are about 90,000 people on the kidney transplant list. Every 14 minutes, somebody's added, or 3,000 patients a month. 13 people on that list die every day without being transplanted. Another 3,600 become too sick to be transplanted. Last year, they transplanted about 25,000 people. So that leaves quite a gap. Can you please explain the need for xenotransplantation?
Absolutely. I mean, you did a great job outlining it there. But if we back it up even further, we know that there are about 37 million Americans that carry the diagnosis of chronic kidney disease. And some percentage of those patients will progress in their disease and ultimately develop end-stage kidney disease. And as you highlighted, there are about 800,000 people who carry that diagnosis. And of those, 600,000 actually are on dialysis. And what we know is fewer than 100,000 of those patients ever make it to the kidney transplant waiting list. And that's because we have such a huge gap between supply and demand that the criteria for waitlisting are quite strict. And this is really problematic because we know that kidney transplantation is in fact a cure for end-stage kidney disease. So ideally, we would want to be able to have a kidney not just for every single person on the waiting list, but also that entire 600,000 individuals that are on dialysis. And we've just never been able to meet the demand with human organs, whether it be living or deceased donation. We only perform about 20 to 25,000 a year, and we know we need about 600,000. So really we have to sort of think through and think about, are there alternative organ sources out there? And certainly xenotransplantation affords an opportunity to help narrow that gap between supply and demand.
Are we talking about a potential increase in preemptive kidney transplants? Because when I've heard you speak about it before, and I see the writings from the university, they mostly emphasize the number of people that actually have kidney disease.
Yeah, I mean, it would be great. I mean, ideally, we would love to transplant every patient before they ever touch dialysis. So we would love to be able to transplant people preemptively. And that really has just never really been something that we've been able to consistently do. There are certainly there are some people who manage to do that, but in general, we're not able to accomplish that. But if we had an unlimited supply of organs, then we could actually hopefully help people avoid dialysis altogether. And that certainly would be a long-term goal of xenotransplantation.
Okay. The idea is that xenotransplantation then may fill the gap. Do you feel that this would eliminate the wait list, possibly give people the opportunity to have transplant on demand?
I think certainly that is a possibility. I think it's a little bit in the future. I don't think that's going to be immediate. We know with this particular series of genetic modifications, about a third to a half of humans will have a negative cross match, meaning they will be a tissue match with that genetically edited pig. So it probably means we will have to look at other edits in order to have pigs that match everyone. And so that'll be something that we continue to work on. But even if we could have a pig kidney that worked for 50% of the people in need, and then we can do another 25,000 of human to human allo, that almost wipes out the waiting list in a year. So it certainly would make a huge dent.
Okay. A pig kidney looks and functions like a human kidney. The GFR is similar. A pig's life expectancy is about 30 years, could last a human 30 years. This particular animal can reproduce quickly with large litters to meet the need. Are there other benefits to the possibility of xenotransplant with a pig kidney?
Yeah, I mean, I think you've highlighted the vast majority of them, which is that they do have a long life expectancy. So we would expect the organ to last the lifetime of the patient. They do function very similarly to human kidneys. And importantly, as you mentioned, they breed quickly, and they also have relatively large litters. So that sort of suggests that we should be able to keep up. And then certainly with the invention of CRISPR-Cas, which is the genetic editing tool, that's really sort of enhanced our ability to do these genetic edits, to do them very quickly and very precisely. And you may recall that the Nobel Prize in Chemistry went to the two scientists who actually discovered CRISPR-Cas.
Okay. Let's talk about the science that went into the pig kidney into an adult environment, specifically the human preclinical model. It's my understanding that UAB was the first to publish the results of a human preclinical model to safely test the feasibility of such a transplant into a 57-year-old male brain-dead organ recipient. Can you please explain how you can transplant a kidney from a pig and have it tolerated in a human adult environment?
Yeah, absolutely. It's a great question. One of the things that we needed to do is we had some additional testing that we felt like we needed to do that we could not accomplish in a non-human primate model. Specifically, we needed to be able to develop an assay to test for tissue compatibility between the pig and a human. And then we needed to be able to validate that test by actually performing the transplant and demonstrating that it did not hyperacutely reject, meaning that it rejects shortly after reperfusion. And that's really what sort of brought us to this preclinical human model where we leveraged human brain death to be able to test this. And the advantage was that there was no harm to a living person. And so what we did is we actually developed a cross match specific for pig to human. And we predicted ahead of time that this particular recently deceased human would actually have a negative cross match with this pig. And that's exactly what you do in human to human allotransplantation. We don't take patients for transplant without knowing their cross match results. In other words, we want to make sure it's a tissue match. And then we actually went ahead and did the transplant. And when you look at the pictures and you see that the kidney turned beautiful and pink and did not turn black on the table, that shows you that there was no hyperacute rejection. And that really validated that test. And that's a really important thing to have before we move this into living people, because we want to know ahead of time whether or not the person's going to be a match with the pig. We don't want to learn that in the operating room and have the transplant be futile. And so I really think that was probably one of the most important findings from our study.
Okay. Can you talk about some of the similarities between a pig kidney and a human kidney and contrast that to the differences? Specifically, I'm wondering about size issues, things like that.
Yeah, so the pig kidneys grow to an appropriate size that are comparable to a normal adult-sized kidney. So a normal adult-sized kidney is typically about 5 to 7 centimeters wide and somewhere between 9 and 13 centimeters long and weighs about 160 or so grams. That we can tell exactly on the growth curve when the pig is going to have kidneys that are sized exactly like that. So essentially they look exactly like a human kidney. They have an artery, a vein, and a ureter, which is the tube that carries the urine from the kidney to the bladder. It looks essentially the same as a human kidney.
Okay. Let's talk about some of the issues that you had to overcome in order to make such a transplant. For example, a pig gets to be pretty big. When it grows, its kidneys grow, right?
In general.
How did you manage the size issue with that?
So early on, there was some data in the non-human primate models in which the pig kidneys would outgrow their host. And so one of the last genetic modifications that was made that made the 10 gene edited pig was the knockout of the pig's growth hormone receptor. And that really keeps that pig kidney from continuing to grow inside its new host. And so it kind of, if you will, kind of helps fix its size. And so that was one of the genetic modifications that we needed to make so that the pig kidney wouldn't continue to grow thinking it was inside of a pig instead of inside of a human.
Okay. There were other issues that you had to overcome as part of this transplant. Talk to us about hemodynamic stability. What issues did you have to overcome there? Something to do with blood pressure.
Yeah, so the blood pressure between an adult human that may have hypertension, which many of our kidney patients do, it's one of the causes of kidney failure, is very different than the blood pressure of a non-human primate. And these pig kidneys had never been tested in the setting of really elevated systolic or arterial blood pressure. And so one of the things we wanted to do was to ensure that the pig kidney and its blood vessels could withstand human arterial pressure. And so we were able to show that in this study, and we did not have any bleeding complications as a result of those new connections or anastomoses between the pig blood vessels and the human blood vessels. And that was really important. Again, another key safety metric that we really needed to understand before we move that into a living person, where certainly having a major bleed like that from the blood vessels could potentially be catastrophic in a living person. So it was important to show that.
Okay. Talk to us a little bit about immune rejection and the 10 gene edited pig. 4 genes knocked out, 6 human genes knocked in. How did all of that work?
Yeah, I mean, really, those genetic edits are designed to modulate the immune response. This is not a tolerance model. So these pig kidney transplants have to be done in the context of immunosuppression, just like human to human allotransplantation. But the pig kidney has been genetically modified enough that we're able to get a good tissue match between the pig and the human, such that in the context of standard immunosuppression, just like we use in human to human transplantation, we don't see early rejection. And so that's really how this model works.
Okay, and there was cross-match screening. Can you address that issue?
Yeah, as we discussed, the cross-match was negative, which means that we felt there was a good tissue match between the pig and this particular recipient. And we validated that after transplanting the kidney and demonstrating that it did not hyperacutely reject, which was great.
There was one big unknown concerning the exact antigens recognized by the antibodies and whether or not there would be an acute rejection. Can you discuss that with us, please?
Yeah, so we did not see a hyperacute rejection, which is what we just talked about. I think there is still lots to learn about sort of acute rejection and whether or not that's going to occur. The preclinical human model only lasted about 3 days. And to really sort of be able to assess that, you have to have longer time points. And so we were not able to do that in this particular case.
Okay. I understand that you were also doing daily biopsies. Can you talk to us a little bit about that?
Yeah, so this was very different than how what would be done in a living person. So this patient was deceased; they were brain dead, and so the recipient actually remained in the operating room with a temporary dressing, so that each day we could easily take a look at the kidney, take tissue samples, et cetera, because this was a part of a safety study. That's certainly not something we would do in a living person. But nonetheless, these data were critical in order to demonstrate safety and feel comfortable moving this into a living person.
Okay. As a result of your work and the actual transplantation itself, do you have an opinion as to whether or not pig kidney transplants can be safely performed under conditions necessary for clinical trial?
We do. I mean, I think we believe that it's time to move this into the living. We think there are lots of questions that are yet to be answered, but that our ability to really be able to do that in a non-human primate model or even in a preclinical model is quite limited, and we need to be able to put this into living persons.
Okay. You mentioned there were some limitations. What limitations are there for the preclinical human model?
What are the limitations for the preclinical human model? Well, it's really just the duration. Brain death is in fact death. It creates a lot of instability. Keeping sort of the body going for a long period of time is not really ideal. And I think the ability to use that model to answer longer term questions like acute rejections and other things is really going to be problematic. And I think the only way to do that is to move it into living persons.
Okay. Do you have concerns about the urine output or what you refer to as slow rejection?
I don't, because again, this was not designed to really assess renal function, because we know from the non-human primate model that these kidneys work and produce urine and create life-sustaining renal function. When you sow a kidney in the milieu of brain death, it's not at all surprising that you're going to see delayed graft function. Oftentimes, when we take kidneys from brain dead individuals in human-to-human transplantation, we see delayed graft function. So again, this study was really designed to assess tissue compatibility, as well as just assess the process of ensuring that we could recapitulate the whole transplant process with the exception of a different donor source, in this case a pig rather than a human.
Okay, let's talk about some of the things to help advance xenotransplantation to the clinic. Things like building a pathogen-free animal facility only for human xenotransplantation, rigorous veterinary care to prevent infectious agents, donor pigs tested every 3 months, herd husbandry, close monitoring of the recipient, monitoring normal human transplants with board review, cross-plant, allotransplant, and immunosuppressive therapy. How does all that work?
I'm sorry, can you ask that again? I'm on call managing a donor offer at the same time I'm trying to do this, and I was managing that offer when you asked the question.
Okay. What are the things that you need to do or need to be done to advance xenotransplantation to the clinic? Some of the things that I saw, a special building, a special animal facility, rigorous veterinary care. The pigs have to be tested every 3 months. There has to be herd husbandry, board review, cross-match, allotransplant, immunosuppressive therapy.
Yeah, I think you're kind of going through the whole list. You're asking me the question, but I think you're actually listing all the things. So I think, when you think about doing this into living people, I think the most critical thing is that the animals really do need to come from a pathogen-free facility, so that we know that they don't have viruses or other things that could be transmitted to a human, and that I think is super important. There's also got to be assays and tests developed to make sure that we can appropriately test people for these viruses, and as well as surveillance systems in place to ensure that we don't have disease transmission. And then I think the other things that we talked about are related to the cross match, which we have now, and certainly just the logistics involved in the transplant itself.
Okay. Please talk about the nature of the FDA approval before you performed the procedure. What was the status then?
Yeah, I can't really talk much about that other than to just tell you that the pig is regulated by the FDA, and so the FDA will have to issue an IND to any investigative team before it could be moved into a clinical trial. So until an IND is issued, we will not be able to move that into living people.
Okay, and has that been requested yet?
I think there are many groups that are working on that. The FDA just held a 2-day conference last week, and I think there's a lot of discussions around INDs at this point. But that's the extent to which I can give you an update on that.
Okay. I have read estimates that about 2/3 of the people may have a negative cross match with pigs. which could lead to maybe 50, 60,000 more transplants a year. Does that jive with what you've learned so far?
Yeah, I think that's fair. It depends on what you look at. Some people say a third, some say 50%, some say 2/3, but a large percentage of humans do appear to have a negative cross match with the pig. And I think any additional source that can help patients on dialysis is much needed. And so I am hopeful that as many as possible will have a negative cross match.
Okay. Explain to us how the UAB Institutional Review Board for Human Use works in this quest to administer genetically modified pig kidneys into living human beings.
Well, the IRB oversees all trials in humans, and they ensure that these things are done ethically and with the proper review and safety mechanisms in place. And so we will work very closely with our IRB prior to initiating any clinical trial. In our preclinical human model, even though technically that does not fall under the umbrella of the IRB because the individual is deceased, we actually did work with our IRB so that they are familiar with what we're doing and really sort of strengthen that partnership as we're looking towards doing a clinical trial in living persons.
Okay, let's talk a little bit about Jim Parsons and his family. How did he come to be the human use and the selfless actions of his family? I understand this transplant took place September 30th, 2021. Talk to us a little bit about how that developed.
Well, our first goal is to try to have organs placed for the purposes of human-to-human allotransplantation. And when that was not an option for Mr. Parsons, his family had also indicated an interest in potential research. And so that was the point at which we approached them about participating in this novel study. And really, to the family's credit, they felt that this is something that Jim would want as part of his legacy to be able to help the world and help move the needle forward. And so they graciously gave consent for him to participate in this study. And he really is a pioneer in many ways. And we have named this preclinical human model the Parsons model in his honor.
Okay. It's my understanding that Mr. Parsons was in a motorcycle accident. That's how he came to you as a patient with brain damage?
That is correct. I can't go into a lot of details on his study, but it wasn't a motorcycle. It was a dirt bike event, kind of the same thing, I guess. But yes, he had a traumatic injury, and that is how he became brain dead. And at declaration of brain death, his family elected to have him be an organ donor for the purposes of transplant or research.
Let's talk a little bit about the study that you led, which was published January 20th, 2022 in the American Journal of Transplant, and the Parsons model. Why was it important to publish this study, and what was groundbreaking?
Well, I think it's important to publish all science because I think the peer review process is really critical. And that's a very different process than the lay press in terms of critically evaluating the data and ensuring its accuracy, et cetera. And I think what was novel about it, we've covered some of those things. I think specifically the development and validation of the cross-match. That's something that we absolutely have to have. It's a regulatory requirement in human-to-human allotransplant. And so that needed to be developed for pig-to-human xenotransplant. And I think that was one of the most important pieces of the study. The second thing was being able to demonstrate the process that we have a pathogen-free facility, that we were able to procure those pig kidneys in the pathogen-free facility, transplant those into a human and not have a disease transmission. Those things I think were very, very critical to establishing early safety points to make us feel a lot more comfortable about moving this into living persons.
Okay. I also noticed when I was reading through the material from the university that precautions were taken in this case that kind of mimicked phase 1 of a clinical trial. Can you explain why such precautions were taken, please?
Yeah, I mean, I think number one for us, we really wanted this to be a dry run. We wanted to sort of look at the whole process from start to finish of exactly what this would look like if we were going to do this in a living person. So that if there were any kinks in the system, anything like that that we could learn, we wanted to be able to learn it in this setting in which we're not going to actually harm a living person. And so that's why we did it as rigorously as we did and wanted to mimic what we would be doing in a phase 1 trial.
Okay. Talk to us about what you perceive to be on the horizon for pig kidney transplants into human beings. Without violating a confidence, what are your next steps that you can tell us about?
I mean, I think for us, along with other investigator groups, I mean, I think we are really hopeful that we will be able to obtain an IND and be able to move into a phase 1 clinical trial. Phase 1 trials are small trials, they're pilot trials, they don't enroll large numbers of people. They're really designed around safety and efficacy. And then from there, you would move into a phase 2, 3, and so forth, just like any new device or drug product, with the ultimate goal to have it approved so that it could be offered to anyone in end-stage kidney disease. That would be the ultimate goal.
Okay. Do you know at this time if pig kidneys will be a bridge until a human kidney is available, or is it a permanent solution?
That's a wonderful question. We don't know the answer to that. And I think we will only learn that answer by moving it into the living. I think we're going to have to put it in a living person to see whether or not it ultimately is bridge or destination therapy. Our hope is that it's destination therapy.
Me too. I understand that the time frame to possibly do a live human transplant somewhere between a year and say 10 years. Is that fair for me to say?
I think that's reasonable. I think it'll really depend on, how the FDA views the existing data and whether they agree that it's time to move it into living. And I think we need to heed their advice and be patient and work with them. This is a big deal. It's really important that we get it right. We want to help people, not hurt people. But yeah, I think that's a reasonable estimate for when this will hopefully go into the first living human.
I'm a very active kidney advocate, particularly on social media. And when I've read news stories about the various groups that are doing pig transplants or xenotropic kidney transplants, some of the people in some of my groups have expressed concerns about the idea against having a transplanted pig kidney placed in their person. That being the case, what steps, if any, do you think need to be taken to overcome this prejudice?
I think it's really about engaging the community, understanding what people's fears or concerns are and how we might go about addressing those. But in my experience, it's about a conversation. And I think patients as well as the community at large are key stakeholders in xenotransplantation. I think having everyone have a seat at the table to make sure we're addressing those concerns is going to be crucial.
Okay. Doc, I'm sorry about all the leading questions, just so our audience understands.
No worries at all. You have done your homework. I'm really impressed. This is really great. Thank you.
Well, I'm old and sick, but I've got plenty of time. Let's put it that way. My question is, well, I should tell our audience. Doctor's on call. There's somebody waiting for a liver that doctor is trying to help to get that person transplanted. So that's why I've kind of been filling in some of the blanks so quickly. Before we conclude our conversation for the evening, is there anything else that you would like to discuss? Any kind of final statement? Did I miss anything that you feel is important?
Yeah. Thank you so much. I don't. I think it's been really comprehensive. I just want to say, just in general, thank you. And thanks for your patience with me this evening with this call. But just thank you for covering this and for really pushing the messaging around kidney disease. And, we need to talk about these things. We need to get this information out. Knowledge is power. It's really important that people have access to this. And I'm just super appreciative of your interest and your willingness to share this. And I'm excited for the future, and I'm really, really hopeful for our patients that this is going to be something that's really going to move the needle. I'm tired of going to clinic and putting patients on the waiting list, knowing that I don't have enough organs to go around. I'd really like to be able to walk in with a big smile and say, I've got one on a shelf waiting for you. This is going to be a great day.
Great, great. Thank you so much, Doctor. I appreciate you taking time to speak with us. I'll be following developments in the future. I hope as things develop, maybe you'll come back and talk to us some more one day. I'm be happy to let you go now. I've covered everything that I wanted to cover, and I want to make sure that poor individual gets his liver. So,
well, thank you so much, and we'll definitely come back and visit. And you've been great, and everyone have a great evening.
Take care, Dr. Locke. Thank you so very much.
Thank you. Bye-bye.
All right, that's our show for tonight. Of course, as always, if you have questions about kidney transplants, contact Kidney Solutions at 830-285-2140 or info@kidneysolutions.org. There's the link that you can subscribe to on my YouTube channel so you don't miss any broadcasts or you want to catch a replay. As you know, I'll always post the replay over again. You can watch it at your leisure. We seem to get more views on the replay than we do on the actual live broadcast, believe it or not. Also, about all the things we talked about tonight, the study, the transplant, the family of the transplantee, all of those things are in the comments to the original broadcast. All of Dr. Locke's prior interviews, YouTube videos, all of that is in the comments. All you have to do is check it out, and we'll go from there. So, all right, that concludes our broadcast. I'm going to let you go. Please check out Kidney Solutions. If you have kidney issues, give my friend Kent Bressler a call, and I hope we learned a little something about xenotransplants tonight. You all have a very good evening. Thank you for watching, and I will talk to you soon.